Yes, I would like to know, because in this case, a PCR was repeated. What is, in your opinion, the role of PCR in case of doubt of recurrence or something else, managing a corneal ulcer?
Well, I mean, clinically, I think you can look at that lesion, and after the first lesion, they were all kind of very neurotrophic, and corneal sensation, which didn't hear about. I'm sure the corneal sensation was zero. So I don't think we need PCR to make that diagnosis. I think it's clinically a neurotrophic ulcer, and we need to then change how we approach the ocular surface: punctal occlusion, bandage lens, tarsorrhaphy, because it's gonna come back. So PCR is certainly not in the U.S. At the level where we use it for routine diagnosis.
Wonderful discussion. Thank you. We'll have Dr. Sarnicola present the next case.
Buon pomeriggio, benvenuti. Good afternoon and welcome back once again to SIXO. Let me introduce a clinical case of a patient who developed a graft versus host disease in a chronic form after transplantation of bone marrow for myelodysplastic syndrome. When the patient presented to us back in 2014, this was his dramatic situation, a bilateral glaucoma with no clear diagnosis. So let me immediately ask you the first question, and let's have the voting start right again. Okay, what's the diagnosis? What do you think of a graft versus host disease, GVHD plus herpes infection, or a microbial infection, or a GVHD plus stem cell deficiency? Se ci fate vedere I risultati. Okay, the results, I imagine that you answered two, although here the slide is the wrong one. However, I think that you have imagined a herpes infection. That is exactly what we thought immediately as soon as we saw the patient. This is, or was his, the treatment he was on when he presented to us. So there was no systemic antivirals at the time, which is normally present in all patients undergoing this medullary transplantation. And so we added cyclosporin, 50 milligram twice a day, prednisolone, and so on and so forth. After a few months, the patient from the ophthalmoscopic view was in a similar situation, but the symptoms had diminished and improved. And especially, he asked us to do something for his visual acuity. So we started from the worst eye. What would you do now? Okay, let's have the vote here. Perforating keratoplasty, PK, and combined with the cataract surgery, DOLC, and tarsorrhaphy, or a DOLC. Okay, doesn't matter. We don't see the results. Let's move on. We thought DOLC plus tarsorrhaphy, because the perforating or penetrating would have a very poor likelihood to survive in such an eye. So the surgical procedure is the most promising. This procedure is the most promising one. And tarsorrhaphy, in order to try and defend the ocular surface. Of course, it wasn't a big bubble. It was a manual DOLC. So layer by layer technique, and we tried to be as deep as possible in order to remove the whole of the stroma, and this is the post-op outcome. After 1 year, we also made cataract surgery, and the final visual acuity was 7 on 10. Here you see the residual bend, which is less than 80 microns, and the patient was very happy because he was given back his driving license. So DOLC and tarsorrhaphy in the fellow eye. But what is particularly interesting is that in both corneal patterns that we analyzed, the PCR was positive for herpes virus type 6. And this is an ubiquitous kind of virus that may cause exanthema subitum, exanthema subitum, which is a childhood benign disease, and the herpes type 6 can be present in 50% of patients receiving bone marrow and 20 to 30% of recipients of solid organ. So this is something that we should always bear in mind when we have to do with these patients. Disinfection results in fever, skin rash, graft rejection, as well as opportunistic fungal infections may, of course, affect the cornea, as it is the case here, and it is better responsive to foscarnet and ganciclovir. We treated him with the ganciclovir because all Italians know what is the enormous difference in price between the two drugs. However, and this is the second eye, that's how we presented 1 month post-op. At the same time, the patient also presented candida pneumonia. So what would you suspect at this point? Would you suspect a reactivation of the herpes, rejection, mycotic infection, or bacterial infection? Okay, results? Okay. Actually, we thought initially of mycotic infection as well, but then, considering the presence of the evolution of the clinical picture, very probably it was a recurrence of herpes type 6. Let's see why. This is the surgery we performed. We replaced we substituted the flap, so we used a topical drug with iodine on the recipient bed, and then voriconazole was used in the first post-op days. But then the culture was negative. The only positive thing was that PCR at herpes type 6. So we have discontinued the treatment. We increased acyclovir, and then we have tapered down it to the maintenance dose, 800 milligrams a day. A few months later, the patient presented with exactly the same issue on the fellow, and here there was a concomitant mycotic otitis. So we thought of a super infection, and so we have replaced once again the flap, but the only herpes 6 was positive. So the patient since September 2016 has been treated with a higher dosage of acyclovir, 1600 milligrams a day, because he is strongly immunodepressed. And now, in May, he came to us with a considerably improved clinical state. This is the visual acuity 6/10 and 5/10 in the left eye. And although there are scars in the optic zone, he's quite happy with his visual acuity. Thank you so much, and we